all my spiel, okay, after all. Okay, so good. Hello, everybody, and welcome to today's webinar. My name is Dr. Belinda Fleming, and I'm one of the nurse scientists here at Tennessee Center for Nursing Advancement, which is the sponsor for today's webinar. The Tennessee Center is dedicated to supporting and empowering the nurse workforce across our great state. Our mission is rooted in advocacy, education, and collaboration as we work to strengthen the nursing profession, addresses workforce challenges, and ensure quality care for every community in Tennessee. We serve as a resource hub for nurses, healthcare organizations, policy makers, and educators, providing critical insights, tools, and initiatives to tackle current issues and prepare for future for healthcare. Whether it's through workforce research, leadership development programs, or partnerships that bring meaningful change, we are committed to advancing the role and impact of nursing in every corner of our state. Today's webinar is a chance for us to connect, learn, and explore how we can continue to make a difference together. Before we dive in, of course, there's some housekeeping things. So here we go. All participants, please remain muted during the presentation to minimize distractions. If you experience any technical difficulties, please use the chat box and our team will assist you. We encourage you to ask questions. Feel free to type your questions into the chat box at any time during the presentation. We'll address them during the designated Q&A at the end. This webinar is being recorded. A copy of the webinar and any shared materials will be sent to you to all registered participants afterwards, so you can revisit the information. All participants will receive a participation certificate via email after the webinar. At the end of this webinar, you'll receive a brief survey. Your feedback is incredibly valuable to us as we continue to improve and deliver meaningful sessions like this one. So with all that out of the way, let me introduce to you Kathryn, or Kat Cooper. She is an experienced acute care nurse practitioner with over 2 decades of clinical expertise spanning emergency medicine, critical care, and hospital-based practice. She earned her Master's of Science of Nursing as an acute care nurse practitioner from the University of Tennessee Health Science Center and has practiced in diverse high acuity settings across the country. Ms. Cooper currently provides critical care and emergency services as a locum tenens provider with extensive experience managing critical ill patients in medical, surgical, and trauma intensive care units. Her clinical expertise includes ventilator management, hemodynamic monitoring, line placement, and complex patient care across a wide range of environments, from major academic centers to rural remote settings, including COVID-19 response. In addition to her clinical work, she has contributed to nursing education as an assistant professor, clinical preceptor, and workshop instructor, supporting the development of future nurses and advanced practice providers. She's actively involved in professional organizations, including American Association of Nurse Practitioners and the Society of Critical Care Medicine. Known for her clinical versatility, leadership, and commitment to excellence in patient care, Ms. Cooper brings a wealth of world experience and insight into her work. And so today, we're listening to her talk to us about CPAP and BiPAP and AVAPS, right?
AVAPS.
Being a primary care provider, all of those are, I've heard the words before. So take it away, Kat.
All right. Thank you so much for having me. I really appreciate it. We're going to talk today about non-invasive positive pressure ventilation. But first, if you can hit that, if you'll notice, there is my husband's name is at the bottom of that slide too, because he did help put this presentation together with me, because I work, I think, 24/7 sometimes, and I needed some help with the slides. So I got to give him a little bit of credit, but not a lot of it, just a little bit. All right, if you could hit that next slide for me. Okay, if we're going to talk just for a moment, we're going to review the mechanics of breathing, which is really what all this is about. So if you'll remember, the act of inspiration is an active process. Breathing is work for some people. And comparatively, the act of expiration is a passive one. So during a normal breath cycle, the diaphragm contracts downward using negative pressure to allow for expansion, causing a decrease in intrathoracic pressure, allowing air to fill the lungs. And when we introduce positive pressure ventilation, whether it's with one of these modalities or with a ventilator, we increase intrathoracic pressure, which we're going to talk about a little bit later, but it's really important to remember how we breathe. And all of this involves respiration, ventilation, and oxygenation. So let's talk a little bit about non-invasive positive pressure ventilation, or NIPPV, as a respiratory support technique. It does not require intubation. We want our learners to have a fundamental grasp of NIPPV, including its mechanisms, settings, and its clinical applications. These goals of using it are very basic. Some of the common goals we're going to talk about include overcoming anatomical airway obstructions, reducing atelectasis, decreasing that work of breathing, improving VQ mismatch, and preventing, hopefully, re-intubation after we've extubated somebody. And strategic use of NIPPV can reduce that need for intubation, which is always our goal. We don't like to intubate people if we don't have to. Okay, next slide. All right, basic understanding. NIPPV should reduce the work of breathing, improving oxygenation, alleviating CO2 retention. So you're going to see it primarily used for acute COPD exacerbations, used in cardiogenic pulmonary edema or acute CHF and other respiratory failures. And I want you to think about, when we talk about this basic understanding, thinking about our DNI patients as well with some of these NIPPVs, because DNR, DNI doesn't mean don't treat. We still have modalities for these patients. So to effectively understand this and how it functions, it delivers positive pressure through a mask, so not intubating or a similar device, and helping people breathe without these invasive procedures. And typically we use a oral nasal mask. It goes like this. It is strapped to the face. You can see nasal pillows when we use CPAP, and we'll talk about that in just a little bit. And in Europe, they have helmets. They come completely over and they're strapped around the shoulders. They're not here yet, but I think that would be really cool. I would love to see a helmet. All right, next slide, please. So when we're talking about these modalities, you'll see settings called EPAP and IPAP, and it's essential to differentiate between the two. I didn't know what the difference was. I just knew there were settings, and it was EPAP and IPAP, and they were magic and did something when I first started out. But it's pretty easy to differentiate the two. One is expiratory positive airway pressure, EPAP, and the other is inspiratory positive airway pressure. It's understanding how these pressures are set and adjusted that's crucial to optimizing these patient care. EPAP is typically used to maintain patency during exhalation, while IPAP assists with inhalation. So inspiratory, expiratory. But there's another way to think about it. IPAP increases your tidal volume, which is the amount of air taken into the lungs while breathing. It enhances CO2 removal, and it reduces that work of breathing, which is, remember, some of these folks have to work really hard to simply breathe. EPAP improves oxygenation, maintains alveolar recruitment, and prevents alveolar collapse. When alveolar collapse, it's very hard to get them to pop open again. So getting the alveoli to pop open and keep them open, it takes much less work to keep them open than it does to pop them open. And where does CO2 and oxygen exchange happen? In the alveoli. So keeping them open is incredibly important. Okay, next slide. All right, so we're going to have questions along the way. So which pressure maintains airway patency during exhalation? IPAP, EPAP, FiO2, which is fraction of inspired oxygen, how much oxygen we're giving you, or tidal volume. So we can cheat because expiratory positive airway pressure is actually in the title there. If you'll go to the next slide. We have our answer. Correct answer is B. EPAP maintains positive airway pressure during exhalation, preventing alveolar collapse, improving oxygenation. And remember, IPAP supports ventilation during inhalation. Those two I's and the E's go together. Okay. All right. So, types of NIPPV. There's 3 types. There's the continuous positive airway pressure, or CPAP, or bi-level positive airway pressure, or BiPAP, and average volume assured pressure support, or AVAPS, which is you don't see very often, but I think is super cool, and I'll try not to go on and on about it. The goal of all 3 is to overcome anatomical obstructions, decrease atelectasis, and improve oxygen saturation. And you're going to see the decreased atelectasis, improve oxygen saturation, and decrease CO2 throughout these slides a lot, because that's what our goals are. So let's talk about CPAP. CPAP, you see at home primarily. We don't use it a whole lot in the clinical setting, but you do see them at home, and they do not have an apnea backup feature. So in all of these, you've got to be able, you would think, to breathe. You've got to have, but CPAP does not have a rate built into it. So you've got to have strict monitoring if we're using it in the clinical setting. And CPAP provides a constant pressure through the breathing cycle. And we'll talk more about each of these in just a little bit. BiPAP delivers different pressures during inhalation and exhalation. That's the IPAP and EPAP. And again, we'll talk about how to set those up in just a little bit. And then AVAPS. AVAPS adjusts the inspiratory positive airway pressure breath by breath. The machine does it, which is super cool. And we set the tidal volume on AVAPS. So, and it changes the IPAP breath by breath, which is really, really cool. And remember, we always want the patient to be able to trigger a breath. This is very, very important. If they're not triggering a breath, then they need to be intubated. Okay, next slide with a little question. So the primary purpose of non-invasive positive pressure ventilation, to provide invasive airway support through intubation, to assist breathing without the need for artificial airway, to completely replace spontaneous breathing, or to deliver medication directly through the lungs. All right, if you'll go to the answer, it is to assist breathing without the need for artificial airway. And an artificial airway, it would be intubation. And remember, it supports ventilatory support through the mask, improving oxygenation and reducing work of breathing to avoid intubation. And we usually with COPD exacerbations and acute respiratory failure. If you'll go back one slide, Belinda, if you don't mind, I do want to. Oh, well, that's okay. If you can't, okay. I do want to point out we can deliver medication directly to the lungs with NIPPV. So but it's not its primary purpose. But you can give breathing treatments and things through NIPPV. Okay, you could go ahead and go forward.
Okay.
All right, go ahead and forward one more. All right, so let's talk about CPAP. So CPAP machine is very common. It's highly effective to treat obstructive sleep apnea. It uses a motor to provide a steady stream of pressurized air through a tube and mask. It helps keep the airway open during sleep to prevent breathing interruptions. And you'll hear people talk about, oh, I stopped breathing 100 times last night, which is absolutely terrifying. It improves sleep quality, reduces snoring, which people absolutely love. It keeps them from killing their spouses, and boosts daytime alertness. It increases the air pressure in your throat, preventing your airway from collapsing when you breathe in. So that's how that works. This device includes a mask, and you may see nasal pillows that just go strictly into the nasal passages. Or you may see a full face mask as well, or you may see a triangle that goes completely over the nose this way. And they too are held in place with straps. So you wear the mask while you're sleeping, at any point. You can use it for naps as well. And if you have somebody who is a mouth breather too, you can get a little chin strap to keep the mouth closed and while the nasal prongs are in place. And if you're not aware, obstructive sleep apnea, we're not talking about central sleep apnea, but obstructive sleep apnea is caused by the throat muscles relaxing and blocking the airway. So that's how the air pressure helps to keep that open. Okay. So we're going to talk about BiPAP, but real quick, we're going to talk about something that BiPAP and AVAPS both do, which is increasing intrathoracic pressure. And I've got a little thing I'm going to help read here, so forgive me while I look down for a minute. BiPAP increases intrathoracic pressure by delivering high pressure during inhalation. Remember, this is positive pressure. Now we're using not negative pressure. Normal breathing is delivered through a negative pressure system. So what are the benefits of increasing intrathoracic pressure for these people? It forces fluid from the alveoli and the interstitial spaces back into the pulmonary circulation, leading to improved ventilation, improved perfusion, and better oxygenation and CO2 exchange. So these folks with our cardiogenic pulmonary edema patients, it's incredibly helpful. So this decreases both preload and LV afterload, which helps reduce cardiac workload and improve stroke volume. Again, so our acute cardiogenic pulmonary edema patients, our CHF patients, incredibly helpful. But you do have to remember, if you have a patient who is dependent on afterload, like your aortic stenosis patients, they can become unstable. And too much intrathoracic pressure, which you'll see on high levels of IPAP, can make your patient very hypotensive. And we see this mostly in our intubated patients, but you can see it in these patients as well. All right, so now let's talk about the creatures that can do this to your patients, BiPAP. So again, this is on a non-invasive ventilator to use to assist breathing by putting pressurized air through the mask with higher pressures during inhalations and lower pressures during exhalations. It helps keep the airway open, aids in exhaling carbon dioxide, and reduces that work of breathing. We use it to treat COPD, and you'll frequently hear about your COPDers retaining CO2. Which makes them very sleepy. You will see it in sleep apnea, especially our morbidly obese patients that don't know they have sleep apnea. We will put them on BiPAP at night. Pneumonia patients that need help opening up those alveoli, and it improves oxygen levels. It reduces CO2, like I just talked about with our COPDers, and decreasing breathing effort. So here's a scenario. You can keep that slide. That's fine. Belinda, you're good. But let's just talk about a scenario on a patient who's been on BiPAP now for a little bit in the ER. Frequently they'll want to be transported on just a non-rebreather, but they've been on BiPAP now for a while, and those little alveoli are all popped open, and we've already started pulling off some CO2 with the airway exchange. So should they be transported on a non-rebreather? The answer really is no. So if you've got an opportunity to keep them on BiPAP for transport, you really should. The other issue is if they're transported on a non-rebreather to the floor, sometimes it takes a while to get them back on BiPAP. You've got things that you as bedside nurses need to do while you're admitting your patient. But really the right thing to do is notify Respiratory, hey, we've got a BiPAP patient coming up, and they need to be put on BiPAP right away when they get there. So you don't want that to take a long period of time to happen when you're getting your patient and getting them admitted. And let's talk for just a minute on how BiPAP is set. You will see an order for IPAP, the EPAP setting, the rate, so there will be a rate set, and FiO2. And depending on what is being treated, will depend on the settings. So you would expect your IPAP to be the higher number and your EPAP to be the lower number. So you'll see a generic setting is typically 10/5 with a rate of, let's say, 12, depending on what you're wanting to do, and an FiO2 depending on what your pulse ox is showing. So if your pulse ox is low, clearly your FiO2 would be higher, 80 or whatever percent. But if your SpO2 is 90 to 100, you might just have it at 40%. But that is an order that has to be written by either the nurse practitioner PA or the physician. And that is what the RT will base the settings on. But you are responsible for making sure that order is in there as a nurse. Okay, so AVAPS. AVAPS is pretty cool. And not every ventilator can run AVAPS. This is a average volume assured pressure support. It is a hybrid non-invasive ventilator mode. It automatically adjusts the pressure support to guarantee a target tidal volume. So we are setting the air that gets pushed into the lungs. The respiratory needs, it improves CO2 removal, reduces respiratory effort, and enhances comfort for patients with chronic hypoventilation, COPD, neuromuscular disorders. So especially with our myasthenia gravis patients, use this on. We also use it a lot of times in our respiratory care units as a last ditch effort to not intubate people on our patients that are a little more obtunded, because we can push in a certain volume, set a very high respiratory rate, and blow off a lot of CO2. So this is a setting that you're only going to see, you're not going to see it on the floor. It will be only used in a respiratory care unit, like a step down respiratory care unit or in the ICU. But it does adjust automatically the IPAP breath by breath. So you don't set that to achieve a target tidal volume. And again, we do set a rate with this and the FiO2. So it's a super cool setting. All right, next slide. All right, so hospital and clinical recommendations. Acute COPD exacerbation with a pH of less than 7.35. Cardiogenic pulmonary edema, again, think CHF, as a bridge to avoid intubation. Acute on chronic COPD, bilevel BiPAP is preferred, with a focus on reducing those high respiratory rates because they're working so hard to breathe. They're just in there, just working, and we want to decrease that. And we will use it. We'll use it with COVID-19, and we will use it very, very early on if we think somebody has ARDS, and again with acute hypoxemic respiratory failure. And we'll try to prone people if we can with this. All right, next slide, please. And I did want to remind you with these implementation guidelines, you're not alone in this. Your respiratory therapist is your best friend and who is going to be driving this modality. But that said, while we're talking about interface selection and monitoring, if these alarms are going off on these machines, it is up to you to look at the alarm and let somebody know what is alarming, not just, I don't know anything about BiPAP. I don't know this machine. They'll be fine. You've got to call and let somebody know what's going on, especially if the volume alarm is going off, whether it's too high or too low. They've got a mask leak. That's a big deal. So you have got to let your respiratory therapist know what's going on. Your respiratory therapist is your very best friend. And they will fit, when we're talking about interface selection, they will fit these oronasal masks because they have to be fitted well. You can have a very small amount of leakage, but if there's a big leak, there's no way you're going to get the positive pressure that you need. So with these acute cases, we start with a modest pressure. Like I said, a 10 to 12 IPAP and EPAP 4 to 5, and then we start adjusting it. We try to adjust it based on comfort and sometimes ABG results, and sometimes just based on SpO2. And we do monitor their respiratory rate. Remember that tidal volume we were talking about? The machine will usually let you know what kind of tidal volume. We talked about pulling tidal volume, how much tidal volume they're pulling in. And usually that's about 4 to 6 milliliters per kilogram. And are they breathing well with the machine, right? If they're fighting this machine, it can cause trauma to the lungs. Oh, I keep trying to forward the slide, Belinda. Could you forward the slide? Okay. So let's have a question about a patient who has already started on BiPAP. So you got a patient who has a COPD exacerbation. You notice you've got a venous gas, and you notice the CO2 level is up, and they're breathing shallowly. What adjustment would you really want to discuss with your respiratory therapist? An increase in EPAP, an increase in IPAP, a decrease in their FiO2, their oxygen amount that we're giving them, or just take that mask off. Next slide. The correct answer is B. You will talk about increasing that IPAP to help improve their ventilation and enhance their CO2 removal. But remember, it helps increase that tidal volume, and in EPAP, it primarily just affects their oxygenation, not ventilation. So we're talking about pressure principles to correct hypercapnia. But let's talk for a second about what we talk about blowing off CO2 with these COPDers. That's the term you hear a lot. We need to blow off that CO2. And remember, way back in the day when we took AP and learned that CO2 is diffused about 20 times faster than O2. So clearing CO2 from the blood depends on cycling air, right? Breathing in and out air through those alveoli. So what does that mean for that BiPAP setting? So not just necessarily changing the IPAP, but that rate. So if your respiratory rate is set at 12, are you going to be breathing fast enough to, quote unquote, blow off that CO2? The answer is no. Your rate's going to have to be higher than that. So that is one of the changes you will see the respiratory therapists discussing with the APPs or the physicians to decide, hey, what rate do we really need to be on? And a lot of even physicians don't know. And again, you'll see those generic settings, 10/5, rate of 12, and a FiO2 of 40. And I think probably half of my patients from the ER come up like that. Okay, next slide, please. So some contraindications to NIPPV. Not everybody can have BiPAP or AVAPS or even CPAP. So facial trauma or burns, I mean, you wouldn't want that mask setting on any kind of burn or facial trauma. Recent facial upper airway or upper GI tract surgery, upper airway obstruction, right? I mean, you can't push anything down if you've got upper airway obstruction. Inability to protect that airway. If you can't protect your airway, you're getting intubated or clear your respiratory secretions. Impaired consciousness. That is one you've got to be able to, again, protect your airway. And if your consciousness is that impaired, then you're not going to be able to protect your airway. Severe confusion or agitation. Well, why? Because they're going to be pulling off that mask. And you need to know, what's going on. Are they confused and agitated because they're profoundly hypoxic? Vomiting or risk of aspiration? Well, because if they're on that BiPAP mask and they vomit, guess what's going down into their lungs? Whatever was just in their stomach. And allergy and sensitivity to mask materials. Now, can you use restraints with BiPAP? Let's talk about that agitated patient. They're agitated, so we can just tie them down and slap that BiPAP on them. No. As always, refer to your hospital policy as your absolute guide. But in some places, you can use mitts because even with mitts, they could still potentially, get that off if they were going to vomit, or a sitter. But you cannot restrain somebody. They've got to be able to pull that mask off in case they were to throw up, because that is just an incredibly important safety issue. Now, with impaired consciousness in these step down respiratory care units and in the ICU, we will allow people, if their CO2 is higher, if they're a little more obtunded, because we're watching them super closely, we will, with our AVAPS, set their respiratory rate very high to try to blow off some of the CO2 in our more obtunded patients whose CO2 is very high. And some of you have probably seen those patients. Their CO2 gets high, they get very, very, very sleepy. But we really try hard not to intubate them if we don't have to. So if we can get some of that CO2 blown off, get them more weight, and avoid that, we will. Okay, next slide, please. Thank you. So now we've got a patient on NIPPV who becomes increasingly confused and cannot remove that mask independently. What is your priority action? Just continue therapy and monitor them. Apply that restraint to maintain mask placement. Notify the provider and respiratory therapist immediately, or just increase that oxygen flow. All right, next slide. C, inability to protect the airway and altered mental status are contraindications to NIPPV. So the priority is to escalate that care, and the patient may require intubation. So continuing therapy or restraining the patient increases that risk of aspiration and may actually harm the patient. And that is not what we're there for. Okay. All right, potential complications, cardiovascular compromise. Remember, we talked about increasing intrathoracic pressure and what can happen to your blood pressure if we increase it too much. Skin breakdown and discomfort from the mask. I have seen people have severe skin breakdown over the bridge of their nose. You can actually pad the bridge of the nose if you need to. Gastric distension, because we are forcing air. Again, we're pushing air into the mouth and nose, so it can also go down into the stomach, which does increase that risk of aspiration. Pulmonary barotrauma. So if we're pushing too much air into some of these very fragile lungs, we can harm the lungs. Risk of sputum retention, or they can just get too tired and have respiratory failure or respiratory arrest. So these patients that are fragile, they can still arrest and need intubation. And respiratory arrest does, of course, lead to cardio arrest. So that's clearly not a good thing. All right, next slide, please. So you've got a patient on BiPAP who complains of abdominal discomfort and bloating. Which complication should the nurse suspect? Pneumothorax, gastric distension, a pulmonary embolism, or fluid overload? Okay, next slide. And I think you probably all figured out gastric distension, because we're forcing the air into the stomach, and can increase it can cause a lot of discomfort if this is happening. And it really does increase that risk of aspiration, and recognizing this complication is really essential. But I did want to talk about for 1 second, pneumothorax was there, and we did talk about barotrauma being a problem with NIPPV. So how do you know if you've got a pneumothorax? And I know everybody's going to say, well, x-ray, but x-ray is 40 minutes out because they're doing something else and you're way down on the list to get a chest x-ray. And worse, what happens if it's a tension pneumothorax? Do you know how to watch for that? So if you can always listen for breath sounds, that's one way, but sometimes you still do hear a little bit of breath sounds if you have a lung that's down. If you have a tension pneumothorax, the trachea may actually move over, but your patient will become tachycardic and hypotensive. So don't forget to take the full set of vital signs if you think something is going on with the lungs as well. So sometimes we get very focused in on the lungs and we forget to get a full set of vital signs. But if you do think you have got a pneumothorax and your vital signs are off and you have a rapid response team, now is the time to use them. Okay, next slide, please. Okay, and this goes back to general nursing interventions and monitoring. Vital signs, again, respiration, BP, SpO2. Big deals. What is their breathing pattern? What is their chest movement? Do they have equal chest wall movement? People forget that. Are they synchronizing with the machine? Are they using their accessory muscles? Because they can still be get into terrible respiratory distress on these machines. Are they tripoding? Where they're leaning up and having to lean forward to try to breathe. What is your general assessment? Are they sweating? Are they terribly dyspneic? What do they sound like? Are they comfortable? Some of these patients are very comfortable. Some of them are not. Are they coughing? Or do they have a lot of sputum? Because if they do, we need to revisit, are they appropriate for NIPPV? And their neurological status, signs of confusion or tiredness. And let's talk about comfort. This is not painful, but it's not always comfortable either. And your patient may require something to help them relax. So this is why checking that neuro status is pretty important. And be very cautious when you get an order to giving these patients something to relax. Now is not the time to give 2 milligrams of Ativan because your patient may stop breathing. So just because you get an order of a large benzo does not mean you should necessarily give it. You may want to rethink that and ask for a different medication because we typically don't give benzos in these patients. And remember, your assessment is absolutely vital in these patients. I need to know what your assessment was. So I can compare what they were before, what they are now, and what my assessment is. Okay, next slide. All right, so we've got the general interventions, again, washing your hands, standard precautions, but explaining what this is going to feel like will help going back to that comfort. Preparing people will help if they're getting started on BiPAP while you're there. There's a phrase that says, the time to teach someone to swim is not while they're drowning. So slapping BiPAP on somebody and saying, oh, you'll be just fine, just breathe with the machine. Explain to them what's about to happen and how we're going to actually, it may be uncomfortable having this air forced in to their lungs a little bit, but how they need to breathe with the machine. And if it's uncomfortable, we can change the settings to help them breathe a little bit better. So that's why we start with lower settings and work our way up with patient comfort. Make sure the settings comply with the order. Again, that is your responsibility to make sure it does. Make sure the mask fits correctly. If it doesn't, again, talk with your respiratory therapist. A lot of times it fits fine the first time and then something happens or they're getting sweaty and now it's not fitting right. Maybe they needed a different size mask. We all thought it fit fine first time and now it doesn't. Make sure those alarms are set appropriately. Suctioning and mouth care, this is your responsibility, not respiratory therapy. Those mouths get really, really dry. So it's up to you to do adequate mouth care on these folks. Now, let's talk about feeding people on BiPAP. Can you feed somebody on BiPAP? No. I have watched people take the mask off and try to shove scrambled eggs in there and put the mask back on. All you're going to do is have Peepaw or Meemaw inhaling scrambled eggs into their right main stem. This is bad. Don't have to explain that to people. Now, people can come off BiPAP if they're okay and if they're stable enough for meals. There will be an order that says may come off BiPAP for breaks and meals. That is perfectly okay, but not while they're on BiPAP. And you do have to explain that to family members because they get very upset when their family member has not had anything to eat or drink for 4 to 6 hours. It may even be longer. It may be 12 hours if we're trying to get someone over an acute process. But I've watched family members take straws, try to slip them up underneath the BiPAP and give people something to drink. And again, then we've got soda or Ensure in a right lung. And then we've got a horrible pneumonia on top of whatever else has got them so sick that they're on BiPAP. So just one of those things that you need to be aware of. You wouldn't think people would do, but they will. Okay, next slide, please. All right, so what if they can't tolerate any of these interventions? Are we just in trouble? Well, we know there are other low flow oxygen devices like a nasal cannula, an oxymask, a non-rebreather, and they only deliver about 60% FiO2 in a patient who's in respiratory distress. And sometimes we've seen people with a nasal cannula and an oxymask on. They've got everything on their face when they can't breathe. You walk by and wonder what is going on with that poor patient, that they've got every oxygen device in the hospital on their face. But high flow nasal cannula can come close to delivering 100% FiO2, and the patient can tolerate it because it is heated. So high flow nasal cannula is non-invasive. It's a respiratory support system that delivers heated and, you're getting ahead of me, sister. Heated and
something happened.
That's all right. You went up a couple slides, but I got my slides here. Go one forward.
One more. No, forward.
Forward.
Sorry.
You're going backwards.
Sorry.
There you go.
Sorry.
You got it.
Technical
you
problem.
Got it. It delivers oxygen-enriched air at high flow rates through nasal prongs. It does improve oxygenation, reduces breathing effort, and helps wash out CO2. And it's much more comfortable compared to regular oxygen therapies because it is delivering heated and humidified air. So there are, on the next slide, some indications. You've got patients with an SpO2 less than 93%. There is a calculation there that you do not need to know. I do not expect you to call me with this calculation. Do not worry about that. It's kind of a busy slide. Respiratory rate greater than 25. And if you've got a worsening chest x-ray and they just need more oxygen than we're able to deliver with these low flow oxygen systems. Okay, next slide. So how does it work? The mechanism, it provides higher flow rates that match or exceed the peak inspiratory flow. It does give a little positive expiratory pressure, not a lot, but it does wash out the anatomic dead space. And your anatomic dead space is from the mouth to the bronchioles. But with this high flow, it actually is jetting air into the nasal and oropharynx. So your dead space is actually from the trachea to the bronchioles. So it allows for the patient to achieve the same amount of washout from CO2 clearance while moving less gas and reducing the work of breathing. So we use it in acute hypoxic respiratory failure, post-extubation support, and managing more stable COPDers and with bronchiectasis. We usually set high flow with a flow rate between 20 to 60 liters per minute and a FiO2, which is anywhere from 21% to 90. And we do that based on the SpO2. Assuming your patient has a functioning pulse ox, and y'all put pulse oxes in some interesting places. So, and do you need an ABG for that? No, everybody wants an ABG. It's if you don't have a functioning pulse ox or your pulse ox is reading low, then yes, you can get an ABG, and everybody wants an ABG. So I'm going to give you one, and then we're going to be done. So everybody always, the first thing they ask me is, do you want an ABG? Do you want an ABG? So I'm going to give you an ABG with a COPD patient who has a pH of 7.28, a CO2 of 60, and a PO2 of 92. So a normal pH is 7.35 to 7.45. So his is low, so they're acidotic. The CO2 is normal is 35 to 45, so their CO2 is pretty high. And a normal PO2 is 80 to 100, so their oxygen level is pretty good. They're sleepy, but they wake up and will talk to you. So neurologically, they're good. And he's breathing about 10. So they have a respiratory rate. So is this patient appropriate to put on BiPAP or AVAPS? Yeah, I would think so, because they do have a respiratory rate. So they don't need to be intubated. They will wake up. And this is a patient that, again, they'll put on 10/5. Now, the respiratory rate is already 10, and he's not blowing off any CO2. So we would like to start his rate. I'll guarantee you the rate will be set at probably 12, but the rate needs to be more like 20 if he can tolerate it. But we'll normally start about 18 and increase it. So this patient would be a typical patient that we would start on BiPAP in the ER and then see where we end up as he is admitted through the system. So I believe is that my last slide? Let's see, forward that slide and see where we end up. Yes. So that's the bad thing about this is I can't see if anybody was being attentive or playing on their phone. And if there are any questions, I would be very happy to take questions.
Let me see if there's any in here. Someone asked, you mentioned no 2 milligram Ativan. What do you prefer? Morphine?
Yeah. So Brett, you bring up morphine as a great drug for CHF because it does have some vasodilatory effects. So a little bit of morphine is, like you said, 1 to 2 actually works fairly well. You can use, if it is anxiety, you can use some Zyprexa. And it depends on your facility. Some places are, do not like Zyprexa or Geodon or those drugs, but other places do. In the current place where I am, we use quite a bit of lower dose Zyprexa. There is another drug, dexmedetomidine or Precedex, that we use in the ICUs, which is an IV drug. That works really well for anxiety, and a lot of people who are on the floor who we know need to stay on BiPAP will be moved to the ICU just to start them on Precedex for anxiety, so we can keep them on their BiPAP. I saw another question.
What safeguards are in place to prevent lung injury if intubation may be needed?
If intubation may be needed, we will set tidal volume and PEEP, and we check actually peak pressures. The ventilator will tell us what peak pressures are on the ventilator, so we get a whole lot more. Was the question if they were intubated?
It says if intubated may be needed is how it said. Yeah. What safeguards are in place to prevent lung injury if intubation may be needed?
Oh, if you're trying to keep them from getting intubated. So honestly, you've got to watch to make sure that they're not pulling really high volumes on the machine. And yeah, okay, I got you. Thanks, Monica. Because that is a problem, because you really don't want somebody pulling these massive volumes. Like people will pull 1,500 cc's a lot of times if they get panicky. So you can give them something to relax them, because if they're just laying there at rest, that's way too much work. So that is a concern. And if you see somebody pulling big volumes on the machine, and the machine should tell you, there's an alarm set for volume, then you need to notify somebody, because we don't want them pulling volumes that big, especially our COPDers who have these kind of fragile lungs. Did that answer your question?
And yes, she said, what are critical parameters, which I think you did. And then she said yes. The answer was yes.
Okay.
Okay.
Yeah, that's a great question.
Yeah. Any other questions? I don't see any up here
Okay.
in the chat.
All right, good. Because I love lungs, and I could talk for a long time on different lungs, different settings, and that kind of stuff. So
Yeah,
don't ask me other questions if you don't want answers.
that's pretty obvious, Kat. We appreciate
Okay.
it. You know what? And
Okay.
we appreciate your dedication to advancing our careers and our knowledge and actually in advancing the nursing profession, period, as a
Okay.
whole. It's really
All right.
inspiring. We
Well,
appreciate it. We also appreciate everyone, the center appreciates everyone joining our webinar today. And we hope that you gain some valuable insights and that you'll look for more webinars down the road. But before we wrap up, I want to remind you that you'll receive an email shortly containing your participation certificate and access to the webinar. We are also wanting you to know that we are working right now to be ANCC certified as continuing education providers. That's on its way. It's coming in the next few months, hopefully. So there'll be a little bit more about that coming. But thank you again for your participation, and we look forward to supporting you as you move forward in your nursing career. And if there's anything that you think that the center needs to be doing to help you in that, to please let us know. Okay.
thank you
Thanks.
so much.
Thank you.
All
Bye.
righty. Bye.
Uh-oh.